We'll move on to the next session now. Very interesting session. First of all, I call upon our chairpersons, Dr. P. Sriram sir. He is a consultant nephrologist at Medicover Hospitals, Vizag, and Dr. A.V. Vedgopal sir. He is consultant nephrologist at Care Hospitals, Vizag, and Dr. Mohan Maharaj sir to chair this session. And I hand over the session to them.
Good morning. It's indeed a privilege to be part of this critical care conclave. I'm thankful to the organizers for giving me this opportunity, and it is a great pleasure in introducing our teacher, mentor, guide, philosopher, Dr. Rajshekhar chakravarti sir. He is well known in the nephrology circuits, and he is considered as father of CRT in India, and he is now presently the clinical director at nephrology and transplant services at Yashoda Hospital, High Tech City, and long association with Care Hospitals, Star Hospitals, and Apollo Hospital, and he did his nephrology training from none other than Dr. M.K. Mani at Apollo Chennai, and he is a part of so many committees internationally and nationally, and he has delivered a lot of lectures, and I got the privilege of attending so many lectures, and I present Dr. Rajshekhar Chakravarti to this audience. Thank you.
Thank you, Venu, for those kind words. Those of you in Vizag who know Venu very well, you know that he is very generous. You don't believe everything that he says. What he mentioned was, I am well known in nephrology circles. All my life I have been trying to be well known in critical care circles, which has not happened. Anyhow, thank you. Let me start off. The job Dr. Mohan Maharaj has given to me is to give an update on AKI. Not an easy task in 20 minutes, because we think we are trying to or getting to understand a lot more about what AKI is about. Let me start off with a patient. One of the critical care consultants called me some time ago saying his uncle, maternal uncle, came to Hyderabad from Khammam, had a angiogram for some indication, creatinine of 1.3, underwent a PTCA2, left anterior descending. Went back after the procedure, doing well, developed some malaise, came back to Hyderabad after 4 weeks. The serum creatinine tested was 7.4. So I will not go into the details of the case per se. One of the most important concepts you and me should walk out of this hospital is every AKI we know today is going to contribute to CKD burden in your community. If India has today 17% of the population with CKD, a lot of AKI is contributing to that CKD. So this particular patient has, in this category, had an insult within 4 weeks, reached ESRD, went on dialysis. So we do know now, we actually pick up AKI very, very late. Extremely delayed diagnosis of AKI, even in the ICUs. What we should be doing is looking at the susceptibilities. The minute the patient comes into contact with a stakeholder in the healthcare system, there has to be a documentation. Is this patient at risk for AKI? And it is quite simple. You look at the volume status, age, gender, presence of CKD earlier, other diseases like heart failure, COPD, bronchial asthma, diabetes, presence of anemia. So this is what is important even in the ICU. And then look at what is the exposure. This patient had a radio contrast exposure, had a CKD of stage 2, 1.3. So there should have been a set of things in place to make sure this patient doesn't land upon dialysis, which we failed to do. So the entire global community of nephrology and critical care. This is a conference which was in 2019 in Rome. They got supposed to be experts across the world. Some of them are very familiar to you. And we have the nomenclature of AKI and CKD is looked at fresh. You now call only first 7 days after the criteria of creatinine and urine output is met as AKI. After that, you enter into a spectrum known as the AKD. After the 7th day, you label these people as acute kidney disease. And there are a set of recommendations to follow up these patients so that they don't get into the next chronological spectrum of CKD. So in your community, you have normal kidney in many, but those who have had a single episode of AKI no longer get back into this. They transition to AKD and subsequently CKD. You saw a gentleman who had 1.3. Most of us brush it off as normal, giving contrast, don't follow whatever small, simple measures that we have to follow. So what could be the lesion in this patient? Anybody? So most likely we will label it as contrast nephropathy. By definition, contrast nephropathy should recover in 72 hours after the exposure. It could be ATN because of whatever reason. By definition, that also has to recover. AIN is still a possibility. So if you see just necrosis, you call it as ATN. And you see inflammation, you call it as AIN. So AIN is not underreported. Contrast exposure, somebody can develop acute interstitial nephritis. And acute interstitial nephritis can take you to end stage in 4 weeks when you don't treat it. So you have to be aware that these are possible. And what is most likely to my mind in this patient is cholesterol embolism. We should have thought of. And you see these nice clefts, there are cholesterol crystals which are dissolved and there is dense inflammation around which causes again like acute interstitial nephritis. So whenever you see a patient with a raising creatinine, the possibility of simple things like pre-renal to ATN to AIN and sometimes even crescentic GN in the ICU is not uncommon. When we biopsy people in the ICU, we have picked up crescents and then treated them. I will not go into those details. As far as diagnostic workup for AKI, there is not much new. You do spend time doing the routines and then depending on what is the lesion you are thinking of, GN, interstitial nephritis, abdominal compartment syndrome, any suggestion of TTP-HUS, rhabdomyolysis, all these are the things that you consider. As far as AKI management per se, again, the stress is don't look at patients after the creatinine is elevated. Try to come back towards is the patient at risk as soon as you see the patient in your ICU or wherever. And the newer understanding is that AKI is not a single organ dysfunction. The minute AKI sets in, it's a multi-organ dysfunction. We know that there is a circulating levels of lot of cytokines and each of the other organs starts getting involved. We will not have time to discuss in detail. This is data from a contrast AKI study. Those who had a single episode of AKI secondary to contrast exposure, after 2 years when you look at them, they die more often, they come back to hospital more often, they get infected more often, they get more cardiovascular disease. So one episode of AKI changes the protoplasm significantly to bring back the patient again and again to the healthcare setup and the outcomes are not good. What we now know is AKI progresses to CKD but also affects the entire vasculature in the body. The severity of AKI, stage of CKD before the AKI, number of episodes, duration and protein loss at the time of discharge. These are predictive of what happens to patients in the next couple of years. What we call as step ladder pattern. You get one insult, your GFR drops, it will never recover fully. It will recover to some extent. You have next insult, that's how it progresses to end stage. So the other thing that is new is the concept of subclinical AKI. Most of us miss it and we only look at what is called as clinical AKI. The concept of renal reserve is very much established now. Most of us have what is called as a GFR, which you estimate today. That is your DFR today. But if you are subjected to any stress on the kidney, which could be just like your heart rate increases when you run, your kidney GFR increases when there is a stress. And that is mediated by several things. We know now mechanisms, what are the physiological mechanisms, what are the effectors. So this is known as a stimulated GFR or a renal reserve. So I showed you that cartoon. Each one has a reserve. Some of us have a reserve of 40 ml GFR, which we recruit when we get into the ICU or when there is an insult. But some of us, like those who have CKD, 1.3 creatinine will be a GFR of 50 ml. The reserve is close to zero in that person. So this concept is something new. So when you look at every AKI, it leaves behind a significant drop in GFR is because you sometimes knock off the reserve GFR. It could be 30 ml, 40 ml, you totally knock it off. So the next time that the patient comes into contact, you are likely to have a much more sustained insult which translates into CKD. So I just picked up one paper, a glimpse of recent advances. So talking of biomarkers, many of us may be interested. They do talk of the problem again. We are picking up AKI once there is a drop in GFR, whereas the effect is to move it towards at risk, and that is possible by various biomarkers. But are we there to use it bedside? I don't think so. But we have been part of around 3 trials looking at NGAL, and this is the present one going enrolled more than 5-10 patients in India in 10 sites. And we have an interim analysis available which do talk about the biomarkers picking up AKI very early. But then how do we use it bedside? We do not know. How is Demarki different from other biomarker trials? We did this analysis only in those who satisfied a chronic score, what we call as a Malhotra score. So whoever is at risk were subjected to biomarkers also. So based on the biomarker, again what is new in the last 5 years is your staging of AKI changes from 1 S. So where there is no change in urine output, no change in creatinine, but your biomarker is positive, you call it as 1S stage or subclinical AKI stage. Whereas 1A is where your biomarker is negative, but creatinine criteria is met, urine output criteria is met. 1B is where biomarker becomes positive. Similarly, 2A, 2B. And there is some data suggesting if the biomarker is positive, it becomes, outcomes are not as good as biomarker negative, different stages. This is a simple study from Chirag Parikh, who has a patent on interleukin 18 as the biomarker. They did a study on HRS and found that just by doing a simple NGAL, you can categorize patients into HRS, pre-renal and acute tubular injury. So they have a role, and there are a lot of data, Sapphire study, Ruby, then CCL4, which is now the new kid on the block. All of them are biomarkers. I am skipping it, but at this point in time, we know that they have a role to pick it up early. There has been an interest in the last couple of years on urinary sediment, and some of you may be aware, Parazella scoring, presence of the renal tubular epithelial cells. They have a score of 1, 2, 3 with the presence of CAS and RTE cells. This predicts ATN significantly. So in a given clinical situation, and there have been almost 5 different papers which talk of the role of urinary sediment in picking up, and they found that it also predicts RRT down the line. So if you have a gland sediment versus you have a sediment with CAS and renal tubular epithelial cells, and again I will not have time to discuss the papers, but this is something that is very important. This is a paper which talked of urinary sediment in HRS, and they could categorically say that this is ATN and not HRS. So that has a big role. It's a very recent paper, I think 2023. So in the diagnostics, there are new or the update is that biomarkers, there are an explosion of papers, but how do we use them bedside? You and I have to learn to. Epidemiology, there is more and more data coming from across the world. The incidence and also the transition of AKI to CKD is much higher. Mayo has just started a second phase, what is called an AKI AP2, epidemiology 2 study. India is one of the ones picked up. I am the national coordinator for that. We are trying to rope in 10 to 12 centers across the country. Their aim is to get 10,000 patients of AKI and see what is the epidemiology. Organ crosstalk, we know a little more now. I showed you one slide, what are the cytokines and which are the organs involved, but I will not spend time here. We know about cardiorenal, hepatorenal and also ventilatory associated AKI. Pathophysiology, I will just quickly mention, we know a lot more about what is happening in the cell when there is a simple necrosis. And we have now subcategorized them into necrosis, apoptosis, ferroptosis, pyroptosis, mitochondrial damage and autophagy. And this looks like how you categorize AKI into different what we now call as phenotypes and the outcomes. And the major thing with this knowledge is target molecules which can be addressed for future treatment. So you have a AKI, it's not a single disease. It's a huge spectrum and you are going to subdivide them into what actually happened at the molecular level so that you can actually treat based on what happened. This I cannot stress enough. AKI, you get an insult, you get damage. This damage transforms into fibrosis. So we know three mechanisms now. When AKI happens, there is nephron loss. There is always an element of inflammation. And when this inflammation heals by fibrosis, you have islands of fibrosis in the kidney. Even the normal tissue gets bled through this fibrous tissue that is known as vascular rarefication, which causes ischemic damage to the remaining. So that is the mechanism why AKI, every AKI translates into CKD. So when you look at AKI, short-term outcomes, you look at inpatient mortality, length of hospital stay, but long-term is always presence of CKD, new AKI in future, and that cycle goes on. So the recommendation now by International Society of Nephrology and all the other groups is every AKI to be labeled as AKD and then followed up, and there is a recommendation when to follow what severity of AKI. So the now the recommendations from KDIGO is to follow every 3 months after one episode of AKI, look at the protein loss. What is coming up is the BP control post-discharge of AKI. They might not have been hypertensive before, but post-discharge, start looking at them and there is very robust data. Many of them become new onset hypertensives. And what drugs to use? There is some debate about RAS blockade in this group, but whatever is published, this is Assess AKI study, whatever is published to use RAS blockade or not, looks like, I'll just tell you the conclusions of this. Reinitiating or starting RAS inhibitors after patients with AKI is strong indication and looks like they have better benefits. This is after they are discharged. So that becomes part of your AKI care in the ICU. Every AKI patient who moves out, when they get out of the hospital, you put a note, make sure they are followed up and they are initiated on RAS inhibitors. The other group of drugs which are coming up are SGLT2 inhibitors, whether to be used in AKI or not, at least after the discharge, if there is protein loss, irrespective of they are diabetic or not, SGLT2 inhibitors will become standard of care. And these are the mechanisms by which RAS blockade, SGLT2 inhibitor, both of them, they reduce the intraglomerular pressure. So we know CKD starts off and progresses. When you decrease the intraglomerular pressure, they will delay the progression of CKD. This is the sick day rule, and one of the drugs that you tell your patients when they have a loose motion or dehydration to stop is RAS blockade. You use them, but you tell the patient they need to stop when they are dehydrated. So AKI recovery never happens 100%. At least you knock off your reserve GFR. and you have to follow up these patients. There is a lot more we understand now about sepsis and AKI. Dr. Srinivas did tell us some details. I will not spend time here except to tell we are now categorizing them on different phenotypes, endotypes and subphenotypes. He did tell you what happens if somebody gets more renin in the circulation. So we know sepsis AKI is not a single one. There are at least 4 subphenotypes. So all your further studies are going to look at them in detail. For example, if the requirement of Narayana is low or high, their outcomes are different. So you manage them differently. So these are not a single group of patients. That is a new understanding. The thing about HRS is you no longer call it as HRS, it's a hepatocardio-renal syndrome. That is the update, and there is a lot of data which talks about, apart from volume overload in the wrong places, there is a significant neurohormonal activation along with portal hypertension which causes it. Therefore, you are looking at giving vasoconstrictors at the same time mobilizing fluid from wrong places into the correct places. There is a lot of data on HRS new. So this is something that you and I should spend some time. When you have a fluid overload patient, your intratubular pressure, intravenous pressure goes up. Normal GFR, which is because of a filtration pressure, drops because of a simple fluid overload state. Just by a 5% increase in your body weight, because the fluid that you are given, you can cause a new onset AKI. Which tells you should be very careful, and this model, though originally from surgical patients, rescue, optimization, stabilization and de-escalation. So in the ICU, you start looking at your patients volume-wise every day. My suggestion is no ICU patient should have on that day intake output. It should have cumulative balance since the time that the patient has come into the ICU. Cumulative balance and more than 5% irrespective of the type of patient. It could be ARDS or any other. The other thing new is role of hypertonic saline in the ICU, including in heart failure. There is a very robust couple of papers which talk of instead of giving volume more, restrict the volume to hypertonic saline and use diuretics. The outcomes are much better. At least 3 different studies. I will not spend time on that. As far as RRT, there is timing, data on timing, access, modality, dose, anticoagulation, weaning. Under subheadings, some new understandings. Anticoagulation, many of you may be knowing. Citrate has become standard of care for anticoagulation in the ICU with good outcomes, not only in septic patients, in others also. So the other thing is precision dialysis. You don't give a protocol, but you look at the patient on a daily basis and change the modality you use, the prescription you use, the clearance you use. That is what is the trend now, what we call as precision CRRT. And finally, I would just like to mention, are we using filters for our patients who don't improve? One of the delegates had asked, what do you do in refractory shock? So is there enough data to talk of? So this is one of our patients, post-toxic fume inhalation on CRRT, on a sepsis filter called doramycin, on ECMO. This patient walked home after 14 days in the hospital. So extracorporeal heme absorption, this is something new with or without AKI, most of them with AKI because they have shock, and there are a list of cartridges available when you have a refractory shock, or is there data enough? The reason is to remove either cytokines or endotoxins or both in your patient. And this is a paper I was part of 2022. They have come out with extracorporeal related therapies, acute indications, nomenclature. This is accepted for publication in blood purification. So they talk about all the different filters available in the market today, and India is one of the places which uses a lot of filters. Are we really doing the right thing? Anyhow, we need to learn a little more, but for those of you in the ICU, you should be aware about filters. There are almost 20 of them now for different indications. For rhabdo, you do different. For bilirubin, there is a filter. So we do have some experience, but the take-home message is that filters for sepsis are an accepted modality. Even KDIGO has given one line saying they can be used in patients who need them. And you and I, who are stakeholders, should learn how to use them, which filter, to whom and how. These three things, because that's going to become the standard of care. Thank you very much.